We are live, sir. Dr. IPS has also joined.
Yeah. So we'll just wait for.
Hi, Shreyash, how are you?
Hi, IPS. We are live. So do you mind just beginning things?
Yeah.
Thanks.
Yeah, absolutely. We can start. Yeah, sure. Shreyash, you can introduce. No worries.
Okay. It's from the Association of Indian Orthopaedic, Indian Arthroscopy Society, being the secretary. I am Dr. Samanta. Also, team leader Dr. IPS, who is currently the president, and Dr. Pradip Gupta, who is just the immediate past president. Also, Shreyash is a very good friend of us, and Sandeep Biraris is a EC committee member. So it is a great honor to invite Dr. James Irrgang, who is one of the pioneer. We are really honored from the society that you are live here with us, and all the I welcome all the members of the Indian Arthroscopy Society in this meeting. So, Shreyash, you can go ahead with Dr. James, then we go into the scientific agenda.
Yeah. Hello, everyone, and welcome to this webinar on return to sports testing after ACL injury. Where are we today? Although our methods and techniques and outcomes following ACL surgery have improved in the last few decades, there is still a percentage of patients who are involved in high-level sports who are not able to return back to the same level of function. And this has been recognized to be due to various factors and not just the surgical aspect. And one important aspect in their recovery and return to play is physical therapy and recovery of their function. And to give us an insight and what would be the way forward to help our patients get to that level, we have none other than Dr. James Irrgang from the University of Pittsburgh. It's a well-recognized and renowned university, especially in the management of knee injuries. And Professor Irrgang is also a chairman of the Department of Physical Therapy, School of Health and Rehabilitation Sciences, University of Pittsburgh. His research interests includes development and validation of patient-reported outcome measures, as well as clinical research related to the knee and the shoulder. He is a Pittsburgh graduate and also completed his master's and subsequently a PhD in physical therapy from the University of Pittsburgh way back in 1999, which was his PhD. He's also the vice chairman for clinical outcomes research, Department of Orthopaedic Surgery, University of Pittsburgh. He also has secondary appointments in the Department of Orthopaedic Surgery and Clinical and Translation Science Institute in the School of Medicine. Currently, Dr. Irrgang serves as the scientific director of the American Physical Therapy Association's Physical Therapy Outcomes Registry. He's a member in good standing of numerous societies, and he has extensively published in his field and also written in book chapters. And he travels extensively, both nationally and internationally, to talk on this aspect, which is a very exciting topic. And really, the Indian Arthroscopy Society is delighted and privileged to have his presence today. He's done a lot of work on this, and from a surgeon's perspective, it will be very useful to get an idea on how we can assist our patients in getting back to their level of play following management of their ACL injury. So thank you once again, Dr. Irrgang, for accepting the invitation. And I would kindly request you to please share your screen and deliver your talk. Thank you very much.
Thank you very much. I'm very excited to be here virtually today. And you should be able to see my screen there, hopefully. Can you confirm that?
Yes, we do. Thank you.
Okay, good, excellent. And, worldwide, we're all dealing with COVID, and it's really affected everybody's lives. But one of the things that it has done is actually brought us closer, at least virtually, so that we can share information much more easily than what we might have done in the past. So after ACL injury, for an athletic population, the ultimate outcome is the ability to return to the prior level of sports in terms of the intensity, frequency, duration, performance level, which is often not looked at, absence of symptoms, and of course, we want to prevent re-injury. So let's start with, how well are we doing? What is the rate of return to prior level of athletic activity? Well, the best current evidence is from a systematic review that was done by Dr Irrgang that looked at 7,500 patients in 69 studies. And the return to sports rate is really dependent on the definition of return to sports. So 81% return to some form of sports, 65% return to pre-injury sports, and only 55% return to competitive sports. So it really depends on how you're defining return to sports. The reasons for not returning primarily are related to the fear of re-injury, problems continuing with the knee, and many times there's family commitments or lifestyle changes that occur over time that decrease the opportunity to participate in the same level of sports. So about 7 years ago, we looked at our return to sports after ACL reconstruction. This was a survey that was completed by over 250 individuals. We defined competitive athlete as somebody that was participating in very strenuous or strenuous sports 4 to 7 times a week, and approximately 150 met that definition. Our return to sports was defined by returning to the same type and frequency of sports participation with the same or better marks activity score. So overall, about 54% return to their pre-injury level of activity. However, that return to sports rate was very dependent on the age of the individual. So in our young high school level athletes, 14 to 18 years old, 71% return to competitive sports. For 19 to 23-year-olds, so that's individuals that are college age, 52%. And for those that are 24 years of age or older, only 19% return. When we look at the reasons, predominantly it was fear of re-injury, ongoing problems with the knee, lack of confidence, and then also work and family obligations, and no longer being eligible for competition. In other words, if they were competing in high school sports and they graduated and they weren't planning to participate in competitive sports in college, they really didn't have the opportunity to return to their pre-injury level of sports. So let's now just quickly take a look at what's the rate of re-injury. So again, the best evidence here is a systematic review of 6 prospective level 1 or 2 studies with greater than 5-year follow-up that totaled about 2,000 patients. Overall, the risk of graft failure was about 6%. And the risk for contralateral knee injury was twice that, about 12%. Most recently, the Stability 1 trial that was done by Al Getgood's group, and it was a multi-center international study of over 600 patients. And the primary goal there was to evaluate outcome of ACL reconstruction with hamstring autograft, randomizing a lateral tenodesis. And they defined ACL clinical failure as a persistent asymptomatic pivot shift, as well as graft failure that was confirmed either during revision surgery or MRI evidence of graft failure. Overall, their rate of ACL clinical failure was 32%, much higher than what's been reported in prior studies. It was encouraging that the lateral tenodesis decreased that risk. So the relative risk reduction for a lateral tenodesis was 0.38. However, when the definition was the rate of graft failure, so that's not just a pivot shift or the sense of instability, but true graft failure, the rate was 7.6%, which is more in line with what is reported in the literature. And again, the lateral tenodesis was protective and reduced the risk of graft failure. So factors associated with re-rupture are an increased risk in younger individuals, competitive athletes in very strenuous or strenuous sports, early return to sports. So in our series, 50% of the failures occurred within the first 9 months after surgery. Allograft, I think we've all learned, is a risk factor now for graft re-rupture, particularly in young active individuals, and hamstring autografts, particularly if the diameter is less than 8 millimeters, all contribute to the risk of graft re-rupture. We also have to think about how the surgery was performed. Looking at non-anatomic ACL reconstruction, so this is the in situ forces on the intact ACL, and when the surgery is performed non-anatomically, the forces that the graft sees are less than normal. And the problem is that may protect the graft, but it exposes other joint structures to increased loads, which may be why we see subsequent meniscus injuries, cartilage injuries, and in the long term, osteoarthritis. When ACL reconstruction is more anatomic, the forces within the graft are closer to the normal ACL forces. So here is an anatomic reconstruction, and you can see that these graft forces are more similar to the normal ACL forces. Now, this, what it means though, is that it exposes an anatomically placed graft to an increased risk of re-injury. And therefore, these anatomic reconstructions may require slower rehabilitation to protect the graft. We had the Panther Sports Medicine Consensus Conference, which was an international meeting in Pittsburgh in the June of 2019. And as part of the consensus conference, we published 3 consensus statements. This one is Return to Sport, and it was concomitantly published in just recently in the British Journal for Sports Medicine, KSTTA, and the Orthopaedic Journal of Sports Medicine. And the purpose was to provide a clear definition of return to sport and a description of the return to sport continuum, as well as to provide clinical guidance on return to sport testing and decision-making after ACL injury. So the underlying premise here is that return to sport after ACL injury is ultimately characterized by achieving the pre-injury level of performance. And this begins, it's a continuum. It's not a single event. It's a continuum of return to participation, initially with unrestricted training, then full participation in practice. Then there's a return to sport, but they're not at their pre-injury level of performance. And ultimately, over time, they return to their pre-injury level of performance with that sport. So it's important to realize that this is a continuum, and it's really difficult to measure it as a discrete event occurring at a specific point in time. Other components of the consensus statement is purely time-based return to sport decision making should be abandoned. In other words, I let all of my patients return to sport at 6 months. I let all of my patients return to sport at 9 months. We should stop doing that. And rather than, we have to respect time, but there's other factors that have to be considered in the return to sport decision making. Also, a criterion-based progression involving a multidisciplinary team is necessary. That team includes the surgeon, the sports medicine physician, physical therapist, athletic trainers, the patient, and also the patient's family if the individual is younger than 18 years of age. And again, the patient needs to progress through a structured plan as clinical and functional milestones are met. And that's really going to be the emphasis of the remainder of the talk, are what are those clinical and functional milestones that need to be met to allow the individual to return to sports. So the information that we need for return to sport decision making, we have to begin with an objective examination of the knee. We need to use validated return to sport testing that includes functional assessment as well as psychological readiness. And that's an area that has been ignored until recently. We also have to consider biological healing, contextual factors. In other words, where are they at in their season? How much time left do they have to compete? And also concomitant injuries. How does meniscus repair or meniscectomy or cartilage injuries affect our return to sport decision making? In terms of graft healing, we're well versed in the 3 phases that include synovial envelopment of the graft and avascular necrosis, followed by revascularization, cellular proliferation, and collagen formation. Eventually, the graft returns to its normal vascular pattern with remodeling and maturation of the graft. The problem is the time frame is not well known and likely highly variable between individuals. And in a systematic review of graft healing, you can see the variability of the early phase, the remodeling and maturation varies across studies. So that's the reason why we're really not able to use time as the sole criteria for return to sports. Dr. Chu has used quantitative MRI to evaluate graft healing And you can see here that at 6 months, the graft is highly vascular and not mature, whereas at 24 months, you know, the graft is less vascular and more mature. So, you know, perhaps in the future, these techniques will be clinically available, where we can do quantitative MRI to look at the status of graft healing. But right now, these technologies are primarily experimental and not available clinically. We also have to realize that, you know, the method of fixation needs to be considered, and whether it's a bone block in the tunnel or if it's soft tissue. This, and it may be hard to see, but there's little red dots, which are tantalinium beads implanted in the graft. And you can see that with walking at 6 weeks, there's, you know, micro motion within the of the graft within the tunnel. So we also have to think about not only maturation of the graft, but healing of the graft within the tunnels and the quality of fixation that stabilizes the graft until that graft heals. So our objective examination is what you're all familiar with. We look at swelling, range of motion, and joint laxity. And essentially what we want is a stable knee with full symmetrical range of motion before we consider return to sport activities. In terms of the pivot shift, so I understand that Dr. Musal presented to you last week or so and talked about rotational laxity. And, you know, we think it's very important that the knee is stable prior to return to sport. So we look at the pivot shift and, you know, make sure that they don't have a lot of shifting and that they can control that rotational laxity of the knee. And we recommend, you know, a standardized 3-step pivot shift. This can be recorded or graded according to IKDC guidelines or by the Pivot Shift app that was developed at the University of Pittsburgh. So I'm sure Dr. Musal showed you this, where we record the pivot shift with an iPad. There's 3 markers on the knee, and essentially what we're looking for is the relative motion between the tibia and the femur during the reduction of the pivot shift. And this can be quantified in millimeters. So we routinely evaluate the pivot shift when we're clearing the individual for beginning return to sport. Now, I think it's also extremely important that we understand quadriceps and hamstring strength. And I believe that this needs to be tested in an isolated manner, where we're specifically looking at quadriceps strength or hamstring strength or the combination of the two. So we use an isometric dynamometer that's held in the hand. We test them at 90 degrees of flexion. We use an inelastic strap to help us stabilize. They can push for the quadriceps. They can pull for the hamstring. And this is a relatively low level technology that can be done in pretty much all clinics without having to invest, you know, $40,000 US in a sophisticated isokinetic testing device. A handheld dynamometer is probably about $500 US. Now, if you can't do that, then what we would consider is what they do in the strength and conditioning literature. They use a test that is called a 1 repetition maximum. And essentially, that is looking at the maximum amount of weight that can be lifted one time through the full range of motion. And you iteratively change the amount of weight and increase it to the time, to the level where the individual can't complete the full range of motion. And you establish that on the contralateral leg and then the involved leg, and you make a ratio just like you would do with the isometric or isokinetic testing. So I think, that as long as you have a knee extensor machine in the clinic, you can look at this 1 repetition maximum. Again, it's the maximum amount of weight that can be lifted once. Early on with ACL reconstruction, we might want to protect the graft and only have them go to 45 degrees. Later on, when we are comfortable with healing of the graft in the tunnel and the graft site and so forth, we would allow them to go to full extension. There's also a number of performance-based measures of physical function that we need to do. So this is a very simple test that is done very early. We call it the step and hold test. It simulates the loading phase of gait. Basically, the individual steps forward, flexes the knee, and stabilizes. And they should be able to stabilize the knee and lower extremity without a lot of wobbling of the knee or dynamic valgus collapse, which means their hip adducts, and internally rotates. And we have athletes, or all of our patients really, perform this test 10 to 30 times, and we grade it as pass or fail based on their ability to stabilize the knee. So sorry about that noise. That's what it looks like if they fail the test. Sorry about that. I didn't have the audio turned off on it. So that's a very early test that we can do. Then later on, when they're getting closer to return to sports, we can do the hop test, which you're all familiar with. These are done on the non-involved leg first, and then the ACL reconstructed leg. We do 2 practice trials, followed by 2 maximal trials. We want them to land without the foot moving or touching the other leg down. And we measure the distance from the toes at takeoff to the heel at landing. So here's the single leg for hop. Individual stands on one leg and lands and stabilizes. And we mark the distance from the toes at the start line to the heel at the when they land. Triple hop for distance, so they hop consecutively 3 times. Okay, you can see this individual has a good landing. They stabilize, they don't touch the other leg down. Whereas here, this is an example of a failed landing. So they lose their balance and have to put the other foot down. That doesn't count. We would repeat that test. Okay, so we want to make sure that they stabilize. And then we can do a triple crossover hop. Okay. So this is introducing some rotational stresses on the knee. It's a 15 centimeter wide strip, and they cross over that strip as they hop 3 times. So they go to the lateral side first, then medially, and then back laterally. And then the last test is a 6 meter timed hop. So we measure them in terms of the amount of time that it takes to hop 6 meters. Another test that we do that is very easy is called a drop vertical jump test. So they're on a 30-centimeter box, standing with both feet slightly off the edge. And they drop off the box. They don't jump up off the box. They drop off it, landing on both feet, and then do a maximal vertical jump as quickly as possible, and should be landing in the same position. You can evaluate this subjectively and looking at the position of the knees and so forth. But we started using a Microsoft Kinect sensor with software that was defined or developed by the University of Missouri. And we quantified dynamic knee valgus as the ratio of the distance between the knee and the ankle. So it's a little bit hard to see here, but this is the recording with their Microsoft Kinect, and it measures the distance between the knees and the distance between the feet, and we get a ratio. And that ratio of ankle to knee width is quantified as the amount of dynamic knee valgus. So in terms of rehabilitation after ACL reconstruction, I'm not going to go through all three phases in detail. Generally, we progress from controlling symptoms and protecting the tissue. So decreasing pain and swelling, restoring motion, restoring normal gait, getting the quadriceps activated, all without overstressing the healing tissues. That's phase one. Then it's a matter of going into phase two, which is restoration of motor control. And the last stage is functional optimization. So really what we're trying to do before we get to the motor control phase, which is where our functional training will start, is we want a quiet joint, no pain, inflammation, or swelling. We want a full range of motion symmetrical to the contralateral joint. We want no quadriceps lag, and they need to be tolerating low load, high repetition exercises. And we want them to have a normal gait with no deviations and the ability to normally go up and down stairs. So this is what we're looking for as an outcome of our early phase rehabilitation. And once they achieve that, then they're ready to move into the motor control phase, where here we're primarily working on increasing muscle performance, strength, power, endurance, and addressing neuromuscular control to make sure that they're using good movement patterns. So we focus still on protecting the healing tissues while progressively increasing the load on the knee. We want to maintain range of motion and muscle length. Strengthening of the muscles, the quadriceps is absolutely the most important because it helps to dissipate load on the knee. But we also can't forget the hips, particularly the abductors, external rotators, extensors, the hamstrings, and the core muscles, which are the trunk, including the abdominals and the extensors. We want to emphasize correct movement patterns. We want conditioning to improve cardiovascular fitness. This can be biking, walking, or running during this period of time. And we want to prevent the recurrence of inflammation. So there's a big controversy on, should we be doing open chain, which we call non-weight-bearing exercises, or closed chain, which we call weight-bearing exercises. And, there's an emphasis, or there has been an emphasis on weight-bearing exercises because it's more functional. But the problem is it doesn't isolate the quadriceps. So the quadriceps weakness can persist even though they can do more weight bearing because they're using substitution. They're using the calf muscles. They're using the hamstrings. They're using the hip muscles substitute for a weak quad. They're also generally thought to be safer for early rehab, reducing shear forces, increasing tibiofemoral compression, which stabilizes the knee, and increasing co-contraction of the hamstring. They also incorporate the entire kinetic chain and have an element of proprioception. So when we look at non-weight bearing exercises, we have limited arc knee extension, 90 to 60 degrees early on to, again, protect graft stresses that increase as they go to full extension. But by about 3 months, we are having them go through a full arc of motion. And as long as it's tolerated by the patellofemoral joint. And then we also use leg press and a number of other weight-bearing exercises. So our approach, it's really a combination of weight-bearing and non-weight-bearing exercise. And our focus here now, as long as it's tolerated by the joint, is high loading. And basically we mean that is the amount of weight that can only be lifted 8 to 12 repetitions. So if they can do 20 or 30 repetitions with the weight, it's time to add more resistance. We want to progressively increase the resistance to stimulate strength development. We use a lot of exercises for the entire lower extremity during this motor control phase. As I said, leg extension, squatting, leg press, lunges, step up, step down, a lot of hamstring exercises and hip strengthening exercises, particularly for the gluteus medius and the hip external rotators. There's also a lot of functional training going on at this time with balance and proprioception, fast treadmill, walking, cycling, with resistance and interval training. So eventually they get to this phase where we're trying to optimize function. So this is the final phase. And this is where we focus on interventions to maximize performance of higher level physical activity. So our progression is running, low level agility drills, jumping, which means taking off and landing on both legs, cutting and pivoting, hopping, which means taking off and landing on one leg, and then ultimately return to practice and then return to sport. Our criteria for progression, we have to think about neuromuscular control. What's the quality of the movement? And we can use, some tests like the step and hold, single leg squat test, step up and down test, the drop vertical jump landing test to look at the quality of the movement. We also use, try to quantify quadriceps strength. We use functional testing and performance tests, the hop test, running an agility test, and successful completion of preliminary functional activities. And then we also monitor them throughout the entire time for the absence of pain, swelling, and instability. We don't want them to become symptomatic again. So our criteria to initiate running, we need at least 80% knee extension, either with an isokinetic test, a handheld dynamometer, or that 1 RM knee extension test. We want them to be able to perform single leg squats, as you see here, with good control, and then the step and hold test that we talked about earlier. We also want them to be able to walk fast for 15 minutes without symptoms or gait deviations. Our next progression would be to low-level agility drills. So they really should be able to run 1.6 to 3 kilometers without pain, swelling, or instability. We want strength increased to at least 85% of the contralateral knee. This includes activities like you see here with lateral shifting, forward and backward running, shuttle run, and karaoke. They begin at submaximal effort and gradually progress as tolerated by the absence of pain, swelling, and instability. We then think about jumping. And again, this is landing on both, taking off and landing on both legs. They have to be tolerating running and low-level agility drills that you saw just previously without pain, swelling, or instability. Again, at least 85% quadricep strength. And we want to emphasize good quality of movement, landing soft with the knees flex on the balls of the feet. And then they progress to hopping, sprinting, cutting, and pivoting. And again, they have to basically successfully be able to do the prior task: running, low-level agility, and jumping drills. And again, now we want strength at least 90% of the contralateral leg. So again, return to sport, it's not a single event. Initially, they return to participation in rehabilitation, training, and sport at a lower level than the return to sport goal. Then they progress to return to sport, but they're still not back at their desired performance level. This may mean return to practice first, get comfortable there, then return to games partially, and then ultimately return to performance where they've returned to sport and they're performing at or above their pre-injury level. Now, we haven't talked about it a lot, but we still don't ignore it. We have to consider the psychological factors. And we look at use of the ACL Return to Sport Index that was developed by Kate Webster and Claire O'Dern, so that we consider not only the physical factors and the psychological factors, as well as their social and contextual factors. So this is what is known as the biopsychosocial model of return to sports. It's physical, it's psychological, and it's the contextual factors. All of that has to be considered to achieve optimal functional performance and return to sport. So in summary, an individualized treatment-based classification, rehabilitation, and functional testing and training program is necessary to ensure optimal return to sports and prevention of re-injury. And hopefully this has been useful to you, and I look forward to taking your questions. Thank you.
Excellent. Thank you very much for that very comprehensive but informative talk. Really, you've narrowed down to certain tests which are mandatory or at least cannot be skipped to kind of guide our patients to get back to their level of sport. Does the panel have any questions before I kind of shout out a few? Pratik?
Sir, you can initiate, then later on we
Sure.
will continue.
Now, you mentioned that obviously with the stability trial, we have reduced the incidence of ACL failure. So as I mentioned in my introduction, we have kind of evolved our techniques, and one such technique is doing an ACL repair in a certain group of patients. So from a physiotherapist perspective, what do you feel? Are we getting better? Because even after these meta-analysis, although our techniques in terms of surgery have evolved, the percentage of people who are not able to return to the same level of play more or less remains the same. So which means that there is that psychological aspect, and that the other element which you mentioned, the social element, which really plays a very important part on the athletes, return back to function. What are your thoughts on it?
Yeah, so, I think we are getting better with rehabilitation. I think it's still continuing to evolve. If you look at where we're at now versus where we were at 10 years ago or 20 years ago, we have a much greater understanding. And I think the key is that we've recognized that weight-bearing exercises are not sufficient. We need to do much more than that. We've understood the principles of establishing neuromuscular control and neuroplasticity. So we're now thinking about, neurological and cognitive mechanisms of how to, enhance the training and injury prevention. And certainly within the last, 5 to 10 years, the psychological aspects and the fear of re-injury. And really, some people have a fear of re-injury, but on the other end of the spectrum, you have individuals that have no fear. And, I think the risk of injury can be increased in those individuals that have no fear. The risk of not returning to sport is increased in those that are, have a lot of fear. So the psychological aspect, why we talk about fear, some fear is good, for protection of re-injury. We've got to figure out where that balance is between no fear and being too fearful. So, there's been a lot of work done on that, but we're still not there yet. And the way that we, approach the fear aspect is that we, in a controlled manner, gradually expose the individual to increase stresses on the knee and allow them to adapt and to, to get comfortable with those movements before we then progress them to the next level. So it's that really accommodation and that's going to allow them to reduce their fear. And then, I think the other issue is we still don't know how to measure return to sport. There needs to be a lot of improvement in return to sport and looking at reasons why the individual doesn't. And a lot of it is contextual in that they, no longer have an interest, they don't have time, they've got a family, they've got a job, so they can't get back to the, so we've got to be careful using return to the same level of sport as the ultimate outcome, after, injury. That's reasonable if they're if they're continuing as a competitive athlete.
Correct. So along the same lines, you've been in Pittsburgh for all this while, and you must have seen how Professor Fu and Volker and Professor Hanner over the last 25, 30 years went through different techniques for ACL reconstruction. Initially, we were using PTB, then we moved to hamstrings. Then we realized the importance of the remnant for proprioception and other associated benefits. So we are doing that, but somehow the percentage of return to that same level of activity hasn't changed much. Maybe our failure rates, as you mentioned, the re-injury rates or the failures may have reduced with these extra articular techniques as highlighted by the stability trial. So certainly there is another element, as you rightly kind of highlighted. So from a surgeon's perspective, it is very difficult to try and counsel our patients in terms, because if they are with clubs and all, they have a certain time frame, and there are club physios and so on who want a certain time frame to get an idea. The coaches want some sort of an idea, but as you mentioned, it's no longer time bound. We've realized that it may vary depending on how the patient or the athlete is recovering in terms of going through all the three phases. So certainly it is phase recovery rather than time recovery. So from that aspect, what I want to know from you as an expert from the physical therapy side is that, have we really improved anything, or we're still evolving and we're still trying to get better and better?
Yeah, I think we have improved, but it's still not. We're still not there yet. You know, there's still room for improvement, and you know, so you know, our rehabilitation, our return to sport, you know, criteria have changed and evolved. You know, in preparing for this, you know, and talking to our physical therapist that works with our university team, he's using all new criteria this year for progression that are more stringent than what prior criteria were. You know, and you talk about the coach and, you know, their influence and what they want to know about, you know, when can the athlete go back to sport? And a couple of important things. One is, in the consensus statement, we basically said the coach is not involved in the return to sport decision-making process, okay? And, you know, how do we deal with a coach? Well, you know, we don't base it on time, but we say, this is what the athlete has to do before they're able to get back to practice, or before they're able to try a game, or before they're able to participate in the whole game. So, you know, that's how we try to do it. But, you know, in terms of, you know, it's a continual process of improvement of our rehabilitation as we learn, you know, from our experiences.
Does prehab make a difference?
So the evidence shows, you know, from the University of Delaware that that it does make a difference. However, at the University of Pittsburgh and UPMC, a lot of times we don't, with the high level of athletes, we don't get the chance to do the prehab. On more recreational athletes, we will do that. And some actually, you know, based on that prehab, and they do well and they don't have any instability, you know, they may forego surgery altogether. But that's for, you know, a less active individual that is not participating in, you know, competitive pivoting, cutting types of sports.
Pratik, you have a question?
Yeah, thanks, Dr. Irrgang. It was a very nice talk. I really enjoyed. There's one question I wanted to find out from you was in matter of, as you said, we don't do return to sports time bound. It is that certain criteria have to be met. Mm-hmm. So have you seen over the period of time that first, how much time generally you feel people take to reach that criteria? Is it over a year generally, or is it less? And the second question is, have you seen that time shifting from last, you know, 2-3 years, like people used to achieve and you were able to send them at particular time. Now you are holding them more or less to get the same criteria?
Yeah, so I think the minimum to get back to sport and competing, but probably not at the same level, is probably closer to 12 months. Whereas, you know, before we were sending people back at 6 months, you know, some people were even sending them back at 3 months. But, you know, again, our data shows that, you know, that first 9 months is where, you know, most of the re-injuries happen. And then in terms of, you know, getting back to their same level of performance. So, you know, in a competitive athlete, that may mean they have the same statistics, right? That, you know, if we look in professional American football, we can, and we have an individual that plays at running back, so they carry the ball and they run. We can look how many yards did they gain, for example, what was their average? So there are some statistics that we can use for that. The other thing I think that is going to be developed in the future is the use of other technologies like global positioning systems or GPS systems that will measure the true amount of activity of the individual, so that if we know what their activity level was and the amount of movement that they were doing before injury, we could then use that to monitor them with the return to sport phase and know when they're really, getting back to their prior level. And there's other things that can be looked at in terms of, heart rate, respiration, recovery overnight with respiration and heart rate. So I think that's the new area, is this sports technology that is, going to allow us to better quantitatively monitor the athlete as we're going through this return to sport process. But definitely, the timing has changed tremendously over the last, 5 to 10 years.
So has it increased? You're holding them back more or sending them?
Yes, absolutely. We're going slower. We're definitely going slower. And we've also, you talk about Pittsburgh, we were a big proponent of allograft, and now we're almost never use allograft. Only time would be maybe revision or, a 50-year-old that, is not going to be, highly active. The other trend that we're seeing is, to try to address the graft issues are, moving away from hamstring to, patellar tendon and now quadriceps tendon. So we'll see. We'll see if it's a combination of surgical methods and rehabilitation methods to improve the outcome.
What is your view about regaining knee hyperextension following the ACL reconstruction, and how soon should we aim to regain that?
Good question. So my belief is that we need to get motion symmetrical to the opposite knee. So if they hyperextend, 5 degrees on the opposite knee, that's what we should achieve on the surgical knee. We want to get them to that range as soon as we can. If we, and I would say, ideally between 2 and 4 weeks, and we want to get them there passively, but we also want to get them there actively. And what I mean by that is when they contract their quadriceps with a knee straight, they can get to that hyperextension. A lot of times they get quadriceps weakness, or they co-contract their muscles, or their patella gets bound down, and they can't actively extend the knee to that end range. And I think that causes problems. So we want that early range of motion. Now, of course, if somebody has, generalized ligamentous laxity and 20 degrees of recurvatum, we're not going there with that, ACL reconstructed knee. But we definitely generally want symmetry.
Now, in cases where we've done extensive meniscal repair surgery alongside an ACL reconstruction, like a bucket handle meniscal tear, obviously, like how we have slowed down the rehab for ACL, we also have to go slow to ensure that that meniscal repair heals. Now, does that have any implications in the, the achievement of these 3 phases compared to somebody who just had a partial meniscectomy or just an isolated ACL reconstruction?
Yeah, I would say it primarily influences the symptom modulation and tissue protection phase, the first phase, which is going to generally be, the first 1 to 2 months. So if we have a meniscus repair, generally they are weight bearing in extension for the first 4 to 6 weeks. They are limiting their range of motion to 90 degrees. They're doing just non-weight bearing strengthening exercises. We're not having them do weight bearing, squatting, where you're getting a combination of compression and shear with that. So they're restricted. Once they get on to the later stages, and we're confident that there's been sufficient healing time, then we don't really change all that much. They still have to get back to their other activities. And, we might, with the weight bearing, when we implement those, we might restrict them from 0 to 45 or 0 to 60 initially, and then go deeper a little bit later. So we may, use, modify those weight bearing exercises.
Do you see any role of these portable home use quadriceps stimulators in the regaining quad strength?
Yeah, that's a good question. So I think that electrical stimulation actually can be very beneficial. But it depends on how you're doing the stimulation. It has to be high intensity electrical stimulation that results in a strong contraction of the muscle that is on for about 10 seconds. And then you get a 30 to 60 second rest, and then it's repeated. And they do 10 to 15 repetitions, ideally, every day or every other day. Now, if the electrical stimulation is just causing a little bit of flickering of the quadriceps and not a good sustained contraction, you're probably wasting your time. But, as long as you're getting a sustained contraction. So what I would mean by that is their knees in extension, and it's pulling the patella superiorly. It's getting tension in the patellar tendon. It's extending the knee to end range. That's probably beneficial. But if it's just a little twitching of the muscle, that's not going to be helpful.
Right. Now, in cases where there is a ACL with a MCL, medial collateral ligament tear, there is some debate whether we should use the hamstring graft for reconstruction or not. Now, from a physical therapy perspective, when you evaluate a patient who has used, in which a hamstring graft has been used versus somebody for this reason hasn't, do you really see a difference? And we're talking about, the pivoting type of sports, not the regular running. So somebody like a splinter, does it really affect, or something into football? Would it really matter?
Yeah. So, I think that, generally we don't see a lot of deficits in hamstring strength. You can see small deficits, and it's primarily at the end range of knee flexion is where they're weak. So, the functional significance of that is really unknown. The sprinter, they need their hamstrings to function well with that. So, if you had a national or international level sprinter, I'm not sure that I would, recommend using the hamstring in that individual. And there's other reasons for maybe not using the hamstring, because of the higher rate of re-injury in more active individuals with that. So, but, from a, graft site morbidity, I don't know that it's a whole lot, that it has a big functional implication.
Does cryotherapy help in the early recovery phase?
Absolutely. Helps control pain and swelling. And, we use it quite a bit. And that's the key in the early phase, is to get a quiet knee as soon as you can. Control their pain. They don't have to take as much medication. Get the inflammation down, get the swelling down. That's going to allow their motion to improve. That's going to allow them to do better with their quadriceps.
Great. Pratik, anything else?
Yeah, there was one more, Dr. Irrgang. In your slide, I saw that the teenagers returned to sports for 74%, and then it fell down and it was overall 54, and past 20, it was much, much less. So here you feel it is the tissue factor or the remodeling. What is the issue? Why, because a 22-year-old as compared to 16-year-old is the remodeling, which is the cause of higher rupture?
Yeah, I don't know that it's the tissue healing and properties. I think it's other contextual factors, to be honest with you. I think it's that they don't have the ability to compete in the same setting, that there's other competing factors in their life, and maybe they don't have the motivation or the opportunity to participate. And again, remember, we said they had to get back to the same type and frequency of sport, as well as the same or better marks activity scale. So that means that, if they were a competitive athlete, they needed to get back to competitive athletics, and they may no longer have the opportunity to do that competitive athletics. They might be able to do recreational, say football and pickup game on the weekend, but they're not getting back to, practicing, 6 days a week and a game, every week type of thing, just because they don't have that opportunity. So I think the definition there is, what might have led to that. Because those patients are still very happy with their knee.
Sure. Yeah.
One last question from my end. Now, we really discussed, and you mentioned that the quads plays a very important role. So just some information from your perspective. So when we operate on these patients with ACL injuries, immediately when the first 6 weeks are over, we suddenly notice at the 6 to 8 week follow-up mark that the quads is really gone wasted compared to what it appeared when we just offered them surgery. Now, is it just only because there was, effusion related to the injury, and, we've done the surgery and we've kind of solved that? Or is it that there is a significant amount of inhibition to the quads in that early post-operative phase because we're going slow, and that really, gets the patient to ground zero, and then you got to work all the way up?
Yeah, I think it's all of the above, right? I think, there's inhibition because of pain and swelling, but there's also decreased activity that probably, you get some disuse atrophy as a result of that. So I think it's all of the above. And, that's why, we want to, activate the quad as soon as we can, get that pain and swelling under control, use the electrical stimulation, particularly in that period of time, and get to the point where we can start to focus on the higher amounts of resistance. And if in the U.S., we see some therapy where they don't really progress the amount of resistance that's being used. They increase the number of repetitions as opposed to the amount of weight. That's why when we get to that motor control phase, it's really important that, as we, progress through the rehabilitation, we have to gradually increase that load with their exercise. So we keep the repetitions that they can perform somewhere between 8 and 12. When they can exceed that, then that's time to add more resistance. And then they get to the point where they can exceed, do more than, 12 repetitions with that new weight, then we have to continually increase the resistance. And a lot of times I don't think that happens the way it should, to be honest with you. And if the patient is, exercising on their own at a home or a gym, they need to be educated on how to do that. That's really important.
Great, thank you. Pratik, anything else? Great. Personally and on behalf of the Indian Arthroscopy Society and my co-panelist, Dr. Pratik Gupta and Sandeep Biraris, I would really once again like to thank you for accepting the invitation. Once again, indeed, your talk was very informative, especially from a surgeon's perspective. We've realized and recognized that there are a few milestones which are now phase-bound rather than time-bound, which are very important, and we need to really counsel our patients who want to return back to the same level of sports that they need to be patient, and it's no longer a short time-bound recovery. So thank you once again, and it was indeed a pleasure to have you participate, and we would look forward to similar associations in the future, either virtual or in person, if we can invite you at some stage. Thanks very much.
Thank you very much.
Take care and all the best.
Okay. Yep. Thank you. Very good. Have a great weekend.
Thanks
Take
a lot.
care.
Same to you.
You too.
Bye.
Thank you.
Thank you.
Dear friends, we have very interesting webinar coming up on this Sunday at evening 4 p.m. It's IAS Reconnect Series 9, and that's the 92nd webinar in association with Gujarat Orthopaedic Association. The topic is patellofemoral instability. So stay tuned on 28th September at 4 p.m. Thank you very much.
Great. Thank you, Pratik, and thank you, Sandeep.